Welcome to the deep dive. Today, we're zooming in on mononeuritis multiplex.
Right.
It sounds complex, but think of it like this. Your peripheral nerves are like circuits, right? Powering different bits of your body.
Yeah, good analogy.
Well, mononeuritis multiplex is like having several different circuits blow, but in completely separate areas all around the same time.
Exactly. It's a really specific
Wow.
pattern of nerve trouble.
And our mission today, for you, the learner, is to really nail down what this is all about.
We're aiming to pull out the core, high-yield stuff from our notes, make it clear, make it stick. The essentials for understanding or revision.
We'll cover the definition, causes, symptoms, the works.
Everything you need.
And we're drawing this all from revision notes, covering the key aspects. Okay, let's jump in. Definition first. What exactly is mononeuritis multiplex?
Okay, so fundamentally, it's damage or dysfunction affecting multiple peripheral nerves. Critically, these nerves are in different parts of the body, so they're not connected or next to each other.
Multiple and different. Those are the key words then.
Absolutely. They're what really sets it apart. It's not just one nerve acting up, and it's not a general problem everywhere.
And what happens when these specific separate nerves get damaged?
Well, because these nerves connect your brain and spinal cord out to your limbs, muscles, skin, damage leads to weakness, numbness, maybe pain.
Yeah.
But, and this is really crucial, the symptoms are localized. They only appear in the specific area that damaged nerve supplies.
Right, so you get this patchwork of problems in different nerve territories, not a global issue.
Precisely. It's a type of peripheral neuropathy, sure. But the defining thing is these distinct individual nerves losing function one by one, or maybe a few at a time.
How's that different from, say, polyneuropathy? People hear neuropathy and might think of that.
Good question. Polyneuropathy is usually much more widespread, more diffuse. Think of the classic stocking and glove pattern symptoms in hands and feet, often quite symmetrical.
Ah, okay. So polyneuropathy is like a general fading out, maybe starting at the ends, whereas mononeuritis multiplex is more like specific lights flickering out in different rooms.
That's a great way to put it. Scattered, localized issues versus something more diffuse and symmetrical.
And how do doctors tell the difference in practice?
Well, the patient's story, the history's huge. How did the symptoms start? When? Did this weakness appear here, then a month later numbness started over there? That timeline is vital.
Okay.
And often, underneath it all, the mechanism is ischemic damage. The nerve isn't getting enough blood.
Ischemic lack of blood flow.
Yeah, and a very common reason for that reduced blood flow to nerves is vasculitis.
Vasculitis, inflammation of the blood vessels. You mentioned that's a big player here.
It really is. It's probably the primary culprit we think of. And this vasculitis can be primary happening on its own or secondary, meaning it's caused by something else going on.
Okay, so if it's secondary, what sort of things can trigger vasculitis that then leads to this nerve problem?
It's actually a surprisingly wide range. Certain infections are important things like HIV, hepatitis B, hepatitis C. We need to think about those.
Right, Hep C especially comes up.
It does. Then there are metabolic conditions. Diabetes mellitus is a common link we see.
Diabetes, okay. That affects nerves in other ways too, doesn't it?
It certainly can, yeah. And then, more seriously, sometimes neoplastic conditions like lymphoma or carcinoma can be associated. It's less common, but important not to miss.
Wow, okay.
And there's even a hereditary angle, sometimes conditions like hereditary neuropathy with predisposition to pressure palsies, HNPP.
So infections, metabolic issues, cancer, even genetics, quite a list.
It is. And stepping back slightly, the broader categories include autoimmune diseases. Generally, vasculitis is often part of an autoimmune process.
Right.
We mentioned infections. Hep C, Lyme disease is another example, diabetes, other connective tissue disorders, even certain medications or malignancies, or sometimes just straightforward nerve compression or trauma. Although, again, vasculitis is very often the underlying mechanism.
So if we're talking risk factors for getting mononeuritis multiplex, it sounds like it's mostly about having one of these underlying conditions.
That's exactly it. The risk factors are essentially the presence of those conditions. If you have an autoimmune disease, certain chronic infections, diabetes, your risk is inherently higher because those things cause mononeuritis multiplex.
So finding the risk factor often means finding the underlying disease.
Pretty much, yeah. They go hand in hand.
Okay, let's get into the how. The pathophysiology, what's actually happening to those individual nerves.
So the core process, as we said, is damage or inflammation hitting these specific peripheral nerves.
Mhm.
But how that happens depends on the why.
Right. So take an autoimmune cause. How does the immune system end up attacking the nerves?
Well, in autoimmunity, the immune system basically makes a mistake. It misidentifies parts of the nerve, maybe the myelin sheath or the axon itself, as something foreign, something dangerous.
Like an invader.
Exactly. So it launches an attack, causing inflammation and damage right there at the nerve level.
And what about infections? Do the bugs attack the nerve directly?
Sometimes, yes. Some viruses or bacteria can directly invade and damage nerve tissue. Other times, it's more indirect. The infection triggers an immune response, which is supposed to fight the bug, but that response accidentally damages the nerves in the process, sort of like collateral damage.
Okay, so different mechanisms, but the end result is these isolated nerve injuries. When someone comes in with this kind of scattered pattern, what else might be on the differential diagnosis list? What else could it be?
That's critical. You always have to think about mimics. Polyneuropathy is definitely number one, but we've talked about how to differentiate that diffuse versus localized pattern.
Symmetrical versus asymmetrical, right?
Right. Then there's radiculopathy. That's a problem higher up at the nerve root where it leaves the spine. Different location, often different pattern of symptoms, maybe back or neck pain involved.
Different level entirely.
Yeah. And of course, if it turns out only one nerve is actually affected, well, then it's not mononeuritis multiplex. It's just a focal neuropathy, like carpal tunnel syndrome or something.
So the multiplex part, the multiple nerves, is essential for the diagnosis.
Absolutely. Now, thinking about the bigger picture, epidemiology. How common is this in the UK?
Do we have numbers on that?
Not precise prevalence figures, no. But the key thing to understand is that its occurrence is directly linked to how common the underlying causes are.
Ah,
So if diabetes is common, or if certain autoimmune diseases are prevalent in a population, you'll naturally see more cases of mononeuritis multiplex popping up as a complication of those conditions.
makes sense. It tracks with its root causes. Let's switch to the clinic then. What does someone with mononeuritis multiplex actually experience, the clinical presentation?
It's really variable because it totally depends on which nerves happen to be involved. You could hit a nerve in the arm, one in the leg, maybe even a cranial nerve affecting the face.
So very unpredictable.
In terms of location, yes, but there are hallmark types of symptoms. Asymmetric weakness is a big one.
Weakness, but uneven, like one leg weaker than the other, or weakness in an arm and a foot?
Exactly that. Uneven distribution. Memory tip here.
Yeah.
Think different nerves, different weakness patterns.
Okay.
Numbness or altered sensation is another key feature. Again, in multiple distinct patches corresponding to those damaged nerves.
Not just generally numb feet.
No, specific areas. And pain can definitely be part of the picture too. Again, localized to the affected nerve distributions.
How quickly does this tend to happen? Does it come on overnight?
It's often described as sudden or perhaps more commonly subacute, developing over, say, a few days to a few weeks. Not usually a very slow, gradual thing like some other neuropathies.
Subacute.
Yeah.
Okay. And it can affect limbs, torso, face.
Yeah.
Pretty much anywhere a peripheral nerve goes.
Potentially, yes.
Huh.
And the deficits can be motor affecting strength and movement or sensory affecting feeling like touch, pain, temperature, or often a combination of both.
Right. A real mix depending on the nerve's job. So if you suspect this, how do you investigate? Time for some detective work.
It needs a thorough approach. Starts, as always, with a really detailed medical history. You're digging for clues about those underlying causes we talked about. Any history of autoimmune disease, infections, diabetes, medications.
Looking for the trigger.
Exactly. Then a meticulous neurological examination. Testing strength, reflexes, sensation in different areas to map out the deficits and see if they fit that multiple distinct nerve pattern.
And then specific tests.
Yes, nerve conduction studies, NCS, are really important here.
What do they show?
They measure how fast and how well electrical signals travel along the nerves. In mononeuritis multiplex, you'd expect to find abnormalities slowed conduction, maybe blocked signals in several specific nerves, while other nerves test completely normal. That confirms the multiple distinct involvement.
Okay, that sounds key. What about EMG?
Electromyography, EMG, often goes alongside NCS. That involves putting small needle electrodes into muscles to check their electrical activity, both at rest and during contraction. It helps assess the health of the connection between the nerve and the muscle and can show signs of nerve damage.
Right. So, memory tip. NCS is like checking the wiring. EMG is checking how the appliance responds to the electricity.
Good one. And it's really best practice to consult with a neuromuscular specialist, a neurologist with expertise in these conditions, when ordering and interpreting these tests. They're complex.
Makes sense. Any rule for blood tests or scans?
Definitely blood tests. You'd run a fairly broad panel looking for inflammation markers, autoimmune antibodies, screening for infections like Hep C, HIV, checking blood sugar for diabetes, basically hunting for that underlying cause.
Got it. Addressing the etiology again.
Yes. And imaging, like an MRI scan, might be used sometimes. Perhaps to rule out structural problems compressing nerves, or maybe to look for inflammation along the nerve pathway in certain cases, particularly if vasculitis is suspected.
So the goals are twofold. Confirm it is Mononeuritis Multiplex and figure out why.
Exactly. Because figuring out the why is absolutely critical for treatment.
Okay, so let's talk management. How do you treat this?
It's that two-pronged approach you just mentioned. You have to treat the underlying cause, whatever it is, and you need to manage the symptoms the patient is experiencing right now, the pain, the weakness.
And the treatment for the underlying cause will vary massively, presumably.
Absolutely. If it's driven by autoimmunity or vasculitis, then immunosuppressive medications are usually the mainstay. Things like corticosteroids, maybe other agents.
To calm down the immune system.
Precisely. If an infection like hepatitis C is the culprit, then antiviral therapy is needed. If it's related to diabetes, getting blood sugar under tight control is paramount.
Tailored treatment.
Very much so. And alongside that, managing the symptoms is key for quality of life. Pain relief is often crucial. Physical therapy is really important to help maintain or regain muscle strength and function, adapt to any weakness.
Sounds like it often needs a team approach.
Oh, definitely. You might have a neurologist or rheumatologist involved if it's autoimmune, maybe an infectious disease specialist, endocrinologist for diabetes,
Yeah.
depending on the cause.
And specifically thinking about prescribing, corticosteroids seem common.
Yes, particularly early on to tackle inflammation, especially in vasculitis. Prednisolone is often used, sometimes with intravenous methylprednisolone initially for severe cases. But again, and this is vital, the specific drug, the dose, the duration, it all depends on the underlying diagnosis. You really need specialist guidance here, ideally from a neuromuscular consultant.
So specialist input is key for medication. What about non-drug management?
That's also guided by the underlying issue and managed by the relevant specialists. So a hepatologist overseeing Hep C treatment, maybe a nephrologist involved if vasculitis is affecting the kidneys. It's all part of managing the root cause and its complications.
Okay, a very coordinated effort. What about the long-term outlook, the prognosis, and potential complications?
The prognosis is unfortunately highly variable. It really hinges on that underlying cause, how quickly it was diagnosed and treated, and how much nerve damage occurred before treatment started.
Is improvement possible?
Yes, definitely. If the underlying condition can be effectively controlled, nerve function can sometimes recover significantly. But nerve damage can be permanent. Nerves don't always regenerate perfectly or at all. So irreversible damage is a real possibility, leading to long-term disability, persistent weakness, sensory loss, chronic pain.
That sounds tough. What are the main complications to watch out for?
Chronic pain is a big one. Functional limitations, difficulty walking, using hands, daily tasks, and obviously this can all significantly impact someone's quality of life.
So getting that diagnosis and starting treatment for the cause quickly is really paramount for trying to limit that permanent damage.
Yeah, absolutely crucial. And ongoing management is key too. Regular follow-up, sticking with a treatment plan, it's all aimed at controlling the underlying disease, managing symptoms, and preventing further nerve injury.
Right. So wrapping this up for you, the learner, what's the big picture here? Mononeuritis multiplex. It's not just random nerve issues, it's a pattern.
A pattern that shouts, look deeper.
Yeah. It signals something else is likely going on systemically, affecting these individual peripheral nerves. Recognizing that pattern, the multiple distinct asymmetric problems, is the first crucial step. Maybe a memory tip. Think multiple nerves, multiple problems in multiple places.
Nice one. We've covered a lot today. Definition, causes, how it presents, the investigations, the management strategies.
Hopefully it's giving you some clear, memorable takeaways for your revision.
We hope so.
And thinking ahead, maybe a question for you to ponder. We talked about vasculitis being a major cause. What are some of the key differences between the types of vasculitis that might help you distinguish them if they present with mononeuritis multiplex? Something to explore further.
That's a great point for further learning. And of course, for more resources to help you smash your MSRA and continue learning, do check out pastthemsra.com.
And for loads of free learning materials, don't forget freemsra.com. Thanks for joining us on this deep dive.